gets himself ready, then we will start just on time. Our MC for this evening's activity, she's in the person of, forgive me sometimes, my eyes. How is the program? How come I can't see? Okay, I can't see you. Dr. Frederica Dedo Party, please. Can we put our hands together for her? She takes over from us, from me, and then carry on with the program. Thank you very much.
Thank you. Good afternoon, distinguished guests, colleagues, students, alumni. It's my pleasure to welcome you this evening to day 2 of our public lecture series, held as part of our 25th anniversary celebrations. So I say, Obake, Akwaba, Wezo. Today we've gathered here not only to celebrate and reflect on 25 years of excellence in training health professionals, advancing research, and serving our community, but we've also gathered here to the promise of the next 25 years together. And to start, I would like to acknowledge the dignitaries amongst us. We do have our Provost here, who's been with us from yesterday. We are greatly honored to have you in our midst. Thank you. And then the deans and directors of the various institutes, we say thank you. And thank you to you all gathered here. Every one of you are parts of our 25-year journey. And this is really a testament that the College of Health Sciences is not just an institution, but a community. And for our colleagues and friends who have joined us online, we are pleased and happy to have you. I'm joined today by Dr. Sewa Ameniampo Dosu, who would be signing for us, and also Mr. Charles Mensah Ahento. As mentioned, my name is Frederica Dedo Party. I'm at the Noguchi Memorial Institute for Medical Research, and I'll be moderating today's activity. So to set the ball rolling, I'll kindly invite Reverend Benjamin Abedu from the Surgery Department to lead us in an opening prayer.
Thank you. Shall we please be on our feet? Shall we pray? Father, we thank you for this day. This is a public lecture. It's a service to the community, O Lord. Therefore, we dedicate this service unto you, God the Father, God the Son, God the Holy Spirit. Amen.
Thank you very much, Reverend Abedu. So our theme for our lecture series is to eat or not to eat, dietary habits and the causing of kidney diseases. So if you're a food lover like myself, who enjoys some pork chops and kenke on a Sunday afternoon alongside sobolo, or some angwamo and some protein Sunday evening, and I'm sure this question has been playing on your mind as to if you are served a meal, whether to eat or not to eat. But fortunately, from yesterday, we've had very insightful discussions that has laid the foundation for us to be able to answer these questions and make better dietary decisions. And today we are going to build on that. So may I now invite Professor Michael Ofori, who will give us the welcome address and is acting on behalf of the Provost of the College of Health Sciences. Let us give him a round of applause as he comes. Welcome, Prof.
Thank you very much, Dr. Patty. And good afternoon to you all. Our esteemed Vice-Chancellor, the deans and directors, those who have been able to join and those who have joined online, our faculty, the hardworking staff and students, our distinguished alumni, partners, and stakeholders, our media partners, ladies and gentlemen, I would like to read a message from the Provost for this very special occasion for us. And it is with great immense joy that I welcome you all to the 25th Anniversary Public Lecture, which we started yesterday and continuing today. This is indeed a very special moment for the College of Health Sciences. For 25 years, the college has stood at the forefront of training health professionals, advancing research, and responding to the health needs of our nation and beyond. Our anniversary theme, Transforming Lives Through Excellence in Education, Research, and Healthcare, sums up what this college has been about since its founding. It reminds us of our mission to educate, to innovate, and to serve. At the same time, it challenges us to keep raising the bar in everything that we do in excellence. Over the coming few days, we have lined up a number of activities that will help us to mark the health challenges of our time across Ghana and in the world. We are witnessing a sharp rise in non-communicable diseases, with chronic kidney diseases emerging as a silent but devastating threat. The prevalence of kidney disease in Ghana has increased significantly this decade, adding pressure to an already stretched healthcare system. Poor dietary habits, especially the high consumption of processed, high salt, and nutrient-deficient foods, are fueling risk factors such as hypertension and diabetes, which are leading causes of chronic kidney diseases. Beyond the clinical statistics, these diseases present families disrupted, incomes lost, and communities burdened by the cost of high-term treatment, including dialysis. Yes, there is a hope. Evidence show, and yesterday we listened, that early dietary interventions and medical nutrition therapy can significantly slow the progression of kidney diseases and improve patient outcomes. This makes our team not only relevant but also timely, reminding us that our health is shaped not just by hospital and medicines, but also by the daily choices we make at the dinner table. And we heard this a lot from yesterday's talks. On behalf of the College of Health Sciences, I wish to thank the Vice-Chancellor, the Pro-Vice-Chancellor, and the university leadership for their steadfast support, our alumni for their loyalty, our partners for their commitment, and above all, our dedicated faculty, staff, and students whose passion and service have brought us this far, 25 years. Distinguished guests, ladies and gentlemen, as we celebrate this silver jubilee, let us look to the future with confidence. May the years ahead bring even greater impact, innovation, and transformation in education, research, and healthcare, not only for Ghana, but the continent and the world. I warmly welcome you on behalf of the Provost, and I wish you a fruitful and inspiring lecture today to add on to what we listened yesterday. Thank you very much.
Thank you, Acting Provost, for the inspiring words and for setting the tone for today's activities. Before we proceed, may I kindly invite Prof. Ofori and Prof. Felix Ankuma Santi and our two distinguished speakers to kindly take up the seat up here for us, please. Please, let us give them a round of applause as they come up. We are also live on Radio Universe, so you can join us, and also on the University of Ghana social media platforms. And if you are here, you can take a photo and then tweet College of Health Sciences Lectures, hashtag 25th anniversary. Thank you very much. I'll now invite Professor Grace Lovia Alote Babington to introduce our chairperson for today. Please give it up for Prof. Thank you, Prof.
Good evening. Today is the second day of our public lecture. Our chairman for today is Professor Felix Ankoma Asante. He is the Pro-Vice-Chancellor for Research, Innovation and Development at the University of Ghana. Prior to this appointment, he served as Director of the Institute of Statistical, Social and Economic Research, ISE. I think we have this in our books, and so I'll tell you something that we do not know about him, even though he doesn't want us to say a lot about him. He is an Greek economist. And in 2007, Professor Felix Asante became the first Ghanaian to be inducted into the DAAD-sponsored African Good Governance Network under the patronage of the former President of the Federal Republic of Germany, His Excellency Horst Köhler. Professor Asante has over 110 publications. I found as part of his research that he specializes in health issues, which makes him very suited to chair this function. He has a book. Which he co-authored, and the title of the book is Placing Health at the Center of Development. Also, I found that he has a book chapter titled Determinants of Health Status for Children in Ghana. This makes him very suited to chair this function. Please let's put our hands together for our chair for today. Chair.
Thank you very much. You've really researched on me. Thank you very much for all the kind words. Yes. Representatives from the Ministries of Education and Ministry of Health, the Director General of Ghana Health Service, the Provost, College of Health Sciences, Deans and Directors, faculty, staff, students, distinguished alumni, partners, stakeholders, ladies and gentlemen, good afternoon. It gives me immense joy and indeed a deep sense of honor to welcome you all once again to the 25th Anniversary Public Lecture in commemoration of the College of Health Sciences Silver Jubilee. We are gathered here today not only to celebrate 25 years of excellence in education, research and healthcare, but also to deepen our collective understanding of one of the most pressing health challenges of our time, kidney diseases and their relationship with diet and lifestyle. Yesterday's lecture was both insightful and inspiring. We're taking through the intricate linkages between dietary habits, lifestyle choices, and kidney health. Particularly striking were the two case studies presented of a 50-year-old patient and a 17-year-old patient whose diagnosis and stages of kidney disease were reversed through prescribed diets, lifestyle modifications, and recommended medication. These real-life examples brought to light a critical truth. Kidney disease is not always an inevitable decline. With timely interventions such as dietary adjustment, lifestyle changes, and adherence to treatment, it is possible to slow, halt, or even reverse progression. Today's lecture builds on those valuable insights. We look forward to learning more about management strategies for kidney diseases, with emphasis on the economic implications for patients, families, and our healthcare system. The cost of managing chronic kidney disease is staggering. Dialysis alone can cost a patient thousands of Ghana cedis monthly, a financial burden that very few households can sustain. Beyond dialysis, kidney transplant, though a viable solution, is even more expensive and not readily accessible in Ghana. These costs extend beyond money. They also include emotional strain, productivity losses, and diminished quality of life. This is why prevention early detection, and lifestyle interventions are so critical. They do not only improve clinical outcomes, but also offer significant economic relief to patients and the healthcare system. The role of medical nutrition therapy, public health education, and supportive policies cannot be overstated. Distinguished guests, today's lecture will give us the opportunity to explore 1, innovative approaches to managing kidney diseases, 2, how dietary and lifestyle interventions can be scaled within our health systems, and 3, the cost implications of kidney disease and what it means for policy and practice. The anniversary theme, Transforming Lives Through Excellence in Education, Research, and Healthcare, captures the essence of what the College of Health Sciences has stood for over the last 25 years. It also reflects our charge for the future to continue driving impact through knowledge, research, and practical solutions that improve lives. As Vice-Chancellor responsible for research, innovation, and development, I take pride in the role research plays in generating evidence that informs such important compensations. Indeed, research must not only live in books and journals, it must translate into policies, practices, and everyday habits that change lives. On behalf of the University of Ghana, I warmly congratulate the College of Health Sciences on its Silver Jubilee. I also commend the Provost, faculty, students, alumni, and partners for these remarkable contributions over the years. It is my hope that today's lecture will leave us with deeper insights, a renewed commitment to tackling kidney diseases, not just as a medical issue, but as a societal, economic, and developmental concerns. Once again, you are welcome, and we thank you very much for showing up. Thank you for your attention.
Thank you, Pro VC, for graciously accepting to chair this occasion. We are truly honored to have you. You were here yesterday, and today you are here with us. So thank you, Pro VC. Now we've come to the heart of today's activity, which is to eat or not to eat. If yesterday's lecture didn't get you thinking, maybe today, after listening to the 2 lectures, you have some change of heart as to what to eat and what not to eat. So our first lecture will be delivered by Prof. Vincent Boima, who is a professor of medicine and nephrology at the University of Ghana Medical School. He's also a consultant nephrologist at the Kolebu Teaching Hospital. He's currently the head of the Department of Medicine and Therapeutics and the Nephrology Unit. He's a member of the Colleges of Medicine South Africa, the West African College of Physicians, and the Ghana College of Physicians and Surgeons, and the International Society of Nephrology. He's the lead investigator and co-investigator on various grants. Prof. Boima's research has been on psychological disorders and chronic illnesses, including hypertension, diabetes, and chronic kidney disease. Recently, he has been involved in chronic kidney disease and genetics studies. He's one of the investigators of the H3 Africa Kidney Disease Network, looking at APOL1 risk variants and CKD in West Africa. With a round of applause, let us welcome Prof. Vincent Boima. May I kindly ask our guests to sit here so you can view. Prof, welcome.
So our Pro VC, who is also the chair for this occasion, the rep of the Provost, and then all directors, deans, colleagues, and all here represented. You are welcome to this afternoon's public lecture. And today, I'm not sure whether the lecture is going to be interesting as yesterday or not, but it's certainly a build-up of what started yesterday. I'm going to tell you about what will happen to you if you don't eat appropriately, or the implications of not eating appropriately. Yesterday, you heard all the good things, but today it's not so good, but it's worth listening to so you can take guard. We are talking about kidney disease and its cost implications. So I'll go along this line. I'll try to talk about importance and functions of the kidney. I'll talk about the burden challenges, economics of dialysis and transplantation policy, and access issues in Ghana and Africa, and then a take-home message. So, okay, what's happening to my slides? Okay, so your amazing kidneys actually saves many functions: removed waste products, excess water, balances minerals and chemicals in your body, controls blood pressure, and also is involved in production of blood, and of course maintains healthy bones. It fails to serve these functions, and that's when we become ill. And each of us has at least 2 kidneys located in the abdomen towards the back, which performs these functions. It's when these kidneys fail that we begin feeling sick and having problems. So what really is kidney disease? The green spot you see here, between 60 to 120 of what we refer to as the glomerular filtration rate, or GFR, could be considered as normal kidney function, or a zone where you don't have kidney disease if there are no other markers of kidney damage, i.e. protein in your urine or blood in your urine. Once you're in this zone and perhaps don't have any other markers of kidney damage, you could be considered as not having kidney disease. But once you fall between 15 to 60, at least for 3 months or more, irrespective of whether you have protein or blood in the urine or not, you may still be considered as having a kidney disease. But look at this. It's only when you go below 15, that is when we say you are in kidney failure. So the first lesson for today is that when you wait until symptoms develop and you present in the hospital, it will be too late. It's good for all of us to check very early, and I'm sure Dr. Edu will be talking about this, so you could be detected very early with timely interventions introduced to delay the progression of your kidney disease. Know that in the early stages, as I said, the disease is very silent. CKD, as I said, the burden is high, and the prevalence is as high as 13.3% in Ghana, which is actually higher than the global average of around 10%. And sadly enough, those afflicted are very young in our country and Africa for that matter. Majority are between the ages of 20 to 50, and the median age from our registry is about 45 years, as you can see here. And the main causes that we recorded in our registry are hypertension, diabetes, inflammation in the kidneys, what we call glomerulonephritis, and of course exposure to various toxins in our environment, including the herbs and the herbal concoctions that we use, the exposure to the diclofenac, the brufen, etc. that we use in our environment may be other predisposing factors to the kidney disease that is really becoming a huge problem in this country. Sadly enough, very few people are able to get access to the kidney replacement therapy that they need if they progress to kidney failure. And therefore, there is a huge or a vast unmet need that really requires policy and other stakeholders to really come and help to solve. If you look at this picture, it really tells you the picture, what I was talking about earlier on, that our patients are very young. Look at the red picture, it's the age group of people afflicted with kidney disease in low and middle income countries. And this is an exact mirror image of what is happening in high income countries, where majority of people having kidney disease are above the age of 60 years. So that means that our people develop kidney disease very early compared to people from other high-income countries. This is from our registry. Thanks to Dr. Edu, who actually did this graph very nicely. Most of the people are between the ages of 20 to 50 years. But if you look at Europe, where people on dialysis, most of them are above the age of 60 years, telling you that our patients are very young. That means that we in Africa, Ghana for that matter, developed kidney disease some 20 to 30 years earlier. And we don't have access to kidney replacement therapy, or maybe they are not available, or maybe they are available by few, or maybe unaffordable by most of these patients. So when they are diagnosed with chronic kidney disease, it's a big issue. So this is where to eat the right things becomes the most appropriate thing to go. As the prophecy said earlier on, kidney disease is something you can slow down, you can reverse it as well when you take the right decisions. So, and again, it doesn't come alone. It comes with other comorbid conditions that really worsens our plight. Most of the kidney disease patients have heart diseases, are at risk of developing heart disease. And that is the number one thing that kills majority of them. So timely strategies are required to detect it early and introduce treatment very early enough to delay progression. And you can give these people many years of dialysis as long as the right decisions are taken. And these are very well documented in our guidelines and very well emphasized for evaluation to detect early, timely treatment, modify the risk of all these patients in order to slow down progression or perhaps even prevent the development of the disease in the first place. So in summary, the treatment involves prevention, delaying progression, and when they progress to end stage and have kidney failure, we give them what we call kidney replacement therapy, which is in the form of dialysis or kidney transplant. And that's where the cost problems will start. So looking at dialysis, so dialysis, about more than 50 hemodialysis centers currently exist in Ghana, but most of them are within the cities. More than 7 regions do not have dialysis, and more than 2/3 of all these dialysis centers are privately owned. Few are in the public sectors. Public sectors can't afford to charge high. They charge less than what the actual fee is. And that's why most of the time you hear all this news, there is shortage of consumables, shortage of that and that, etc. And the patients go to the media and all that because they are not charging realistic fees. Even when a fee of 765 Ghana cedis was introduced a few months ago, it became a public uproar in Ghana, which is actually way below what the actual estimated cost of more than 1,000 Ghana cedis per session is. And you go to NHIS is saying charge 491 again, more than what is the realistic fee is. So the gap in between what they are paying now and the actual fee, who pays for it? Those are questions. And then privately, as you can see, the private people are trying to make, not only trying to make profit, but as much as possible, struggling even to break even by charging between 1,000 to 2,000 Ghana cedis per session. It's really a huge issue. You require almost 156 sessions per year because the ideal treatment regimen is 3 sessions per week. So if you are doing 3 sessions per week, it means in a year, you would have done 156 sessions in a year. Multiply that by even 1,000, that is 156,000 Ghana cedis a year on dialysis alone. We haven't counted the cost of your hypertension medication, diabetes medication, treatment for anemia, hospital care, transport in and out of the hospital, feeding, etc. When you add all this, I'm sure they spend more than 200,000 every year just on this treatment alone. How is this affordable by even us here? And I want people to raise hands. I'm sure nobody wants to raise their hands. So, sorry, I need to go back. So, again, the cost of other things that come, and I told you earlier on that the kidneys produce blood. It's a hormone which is called erythropoietin, which the kidney produces. And when the kidney is diseased, because it cannot produce this hormone, it has to be given to you in the form of an injection. And that comes also at an additional cost to the patient. In addition to cost of all other medications for comorbidities, transport, opportunity cost, caretaker, they will lose their job or lose time at work. Reduce income, even for the caretaker who is going to pay for your transport and feed you, etc. All these are a cost burden when it comes to managing these patients. So even if we decide to charge a very low fee at 380 Ghana cedis per session, which we used to charge more than a decade ago, it will come to around 4,000 Ghana cedis per month, which is twice the average minimum wage in Ghana. If we decide to charge 491, the NHIS fee, it comes to around almost 6,000, almost 4,000, 6,000, yes, which is again 3 times the average monthly wage in Ghana. What about the 765 I quoted? Almost 10,000. 5 times average minimum wage in Ghana. How is this affordable by the average person? Dialysis has to be state-funded. That's probably the way to go. So dialysis cost dwarfs Ghana's average monthly wage. So average CKD costs actually bring catastrophic household spending. This was estimated in Confonatia Teaching Hospital, where the household cost per month stood at 3,467, 92% of direct cost. Kolebu Teaching Hospital, an estimate was done as well, and it came to around 4,166 household costs per month. So dialysis patients spend 5 times more than non-dialysis CKD patients spend. Over 85% is out of pocket, as historically CKD or treatment of end-stage kidney disease was not covered by NHIs. Recently, there have been some policy shifts, which I'll come to very soon, for us to know the details of what is going on. So, compared to all other forms of non-communicable diseases, diabetes, cancer, etc., years of life lost to disease or to kidney, for that matter, is much more in CKD patients compared to all these other non-communicable diseases. And once you are diagnosed with CKD, it shortens your life expectancy. So, for instance, if you can live for, say, 39 years when you are within the age range of 40 to 44, that shortens to average about 11 years when you're diagnosed. And that decreases with age. So the older you are, the higher the chances that you will live for a shorter time compared to when you are younger. So, for instance, somebody within the age range of, say, 55 to 59 is probably living less than 11 years, which maybe the 40 to 44-year-old would have lived. But in essence, what it means is that your lifespan is reduced grossly when you are diagnosed with kidney disease. So prevention is key. Mind you, dialysis will not cure you. It doesn't reverse anything. It's only a supportive treatment. In fact, dialysis itself may shorten your lifespan. So, Okay, so here it's telling us about the population experiencing catastrophic expenditure, which is more in CKD patients compared to other non-communicable diseases, healthcare cost, and the cost annual income in the US, for instance, was quoted around $59,000, but the cost of hemodialysis is about $60,000. So again, it's a global phenomenon. The cost of dialysis is really very huge, not affordable by the common person. It needs sponsorship. It needs to be state funded. Here, accessibility is another problem because of cost and establishment of these treatment modalities in our part of the world. So in high-income countries, it's relatively accessible, but in low-income countries where we live, very few people have access to dialysis or kidney transplantation. Majority do not have access. As a result, more than 2 million people may die each year because they don't have adequate access even to this treatment. And I said earlier on, out of the 10 regions or 16 regions in Ghana, very few have access to hemodialysis, and patients would have to travel far and near to get this treatment. Again, the cost is not only on the patient, it affects everybody else in the household, even friends. So caregivers here who lost time at work and therefore lost revenue because they are not at work. And also there's a lot of stress on these people. I remember very well one morning on the ward in Kolebu where a relative of the patient broke down emotionally and started crying. She just came to visit the father in the hospital and broke down because she's been coming there persistently all the time. She's stressed up. Another scenario, which is also a true story, was a mother who comes to visit the son in the hospital all the time. One day he came in the afternoon and then he collapsed. She collapsed herself. So they are stressed and they are embedded, and that cost is another problem altogether. They end up spending their money to transport the patient to the hospital and feed them. They end up being with them in the hospital all the time for their daily tasks and activities. And of course, emotional support may not be there for most of these people. Perhaps imagine you're the only person taking care of your father. Who else is there to support you? So these are all cost implications that come as far as this kidney disease is concerned. So it reduces the quality of life of both the patient, caretakers, even those in the household. So they are at risk of anxiety, depression, social isolation, reduced productivity, increased healthcare costs. Most of these people would eagerly initially want to be alive, and therefore they'll start the treatment. Within a short while, the functional reserve runs down, the family is impoverished. And where do they go? The rest is history. So CKD patients experience significant reduction in employment rates and earnings compared to healthy individuals. They lose their jobs as well. And I think that's one thing that we need to be addressing as a country. Should somebody who is ill always lose their job, or should we really get these people some way, somehow back into society to become more productive? What are the social welfare people doing? How can they be integrated back into society, etc.? Of course, the caretakers are not left out. They get depressed and they experience financial strain. So, what about transplantation? How does it fit in? I heard the Provost say the cost of transplant is enormous and high, but in the long term, it turns out to be more cost effective. So for these young ones in our part of the world who are afflicted by kidney disease, kidney transplant is the way out. And everybody on dialysis should ideally transit from dialysis to transplant to cut down the cost of dialysis treatment on the government and on household as well. So for instance, in Ghana, we spend between $19,000 to $35,000 for kidney transplantation, which is very cheap, depending on whether you are doing the public sector or private sector. In US, it could be as high as 200 for God knows how many years. For God knows how many years. One could give that person a life. upfront cost of kidney transplant could be very high, but the long-term cost from the year 1 after transplant onwards is much less than the cost of hemodialysis, the cost of peritoneal dialysis, etc. So what are the main drivers, the key cost drivers? We import consumables against the volatile exchange rate. And that's key. We don't produce anything in this country. Everything is imported against the foreign currency, the exchange rate. So when things are going bad in terms of the exchange rate, the cost of these treatments will go up. None of the things we use really for dialysis are produced in country, except maybe the normal saline. Almost everything is imported. So you expect the cost to go up. And then import duties and VAT on machines can add as much as 30 to 40% to the capital cost of this treatment. An equal center distribution where the treatment is not available in all regions, so people have to travel, extra travel cost and accommodation wherever they are going would further increase their cost. Late presentation, because the disease is very silent in the early stages, so when they come in with complications already, they spend more to get better before maybe they will stay on maintenance treatment. So all this would heighten the cost. So productivity loss, societal and indirect cost, productivity loss, caregivers and patients miss work, indirect cost, almost 8% of total household burden. Young adults increasingly being affected and therefore shrinking our workforce. So psychosocial stress, schooling interruptions, and all these create a kind of poverty cycle. You use all the scarce resource you have to do dialysis, everything is gone, and then you come back to square one. So even if all the estimated number of kidney failure patients in the country receive, say, 2 sessions of dialysis a week, at an estimated cost of, say, $53 per session, that would amount to about $81.6 million per year, approximately 7.4% of Ghana's health budget. So again, huge implications for the national coffers. Something has to be done. So in the US, for instance, even though patients with end-stage kidney disease account for only about 1% of the Medicare population, they account for over 7% of the total expenditure, amounting to about $50 billion annually. That tells you how costly this treatment is. UK spends about between 30 to 35,000 pounds per patient. Per patient is generally 2 to 3 times more expensive than peritoneal dialysis, but both of this, both hemo and peritoneal dialysis, are significantly more costly than when the disease is detected early and treated very early to prevent the disease itself or delay progression or perhaps reverse the kidney dysfunction. So strategies that can bend the cost curve: prevention and early detection, control of blood pressure, diabetes, community screening to pick up these people early and put them into institutions where they can be followed up for treatment strategies that can delay progression. Duty and VAT exemptions for hemodialysis, equipment and consumables can actually reduce the cost of this patient almost between 30 to 40%. Expand peritoneal dialysis programs in Ghana with local production of consumables. This is a form of treatment that we can produce the consumables locally, and if we are able to do that, it may cut down the cost that comes with this kind of disease. Scale up local production of consumables and bulk procurement programs that can cut down costs. Leverage on philanthropy that can support in terms of treatment. And I'll pause here to actually talk about one philanthropist who has been supporting dialysis patients in Kolabo Teaching Hospital for more than almost close to 10 years now. He's been paying for dialysis patients 2 sessions a week for the past 8 years. He's paid for some transplants as well. He's in the process of paying to support capacity building, to develop more nephrologists, more people in the transplant team, etc. And I think they are doing a lot. They spent over millions of Ghana cedis throughout this period to do it, and I think that they deserve a national award. And I think that everybody else, all stakeholders out there, NGOs, should learn from this person and come to the aid of this patient. So, strengthen NHIS financing syntax. Maybe we should start putting some taxes on cigarette smoking, alcohol, and all those kinds of things. And all these costs or money should be earmarked for kidney treatment. Actuarial reviews will tell us where we are and appropriate the money where it's supposed to be. Public education, lifestyle, hydration, nephrotoxin avoidance are all things that we can do to really reduce the long-term cost burden involved in the care of kidney disease. So early detection, screen, control BP, manage diabetes to delay progression or prevent disease. And then once you do that, you reduce complications and hospitalization, which also brings additional cost for the patient. So cost and versus early CKD and end-stage kidney disease management. Investing in early detection and management of CKD is significantly more cost-effective than when you are treating patients on dialysis. Early detection can actually reduce the cost by almost 50% if we can do that very well. In many sub-Saharan African settings, however, people are diagnosed very late when they already have end-stage kidney disease, making early intervention strategies very difficult. However, through education, I think that we can arrive there. More people becoming aware of the fact that when I'm diagnosed early, I can be helped. That can also be a solution to the problem. So recently there have been policy shifts in terms of support, national support or state funding of dialysis in Ghana. And it was started last year from June, between June and December 2024, where they said that those less than 18 years and those above 60 years will receive 8 free HD sessions per month, and those between the ages of 19 to 59, 2 subsidized sessions per month. After that, by December same year, they came out to say, okay, now they are providing 2 free sessions for everybody. And they were going to support 40 facilities, and the budget was between 20 to 57 million per year at the time. NHIS then pledged that dialysis may become a permanent part of the NHIS benefit package at the time. And that import duties discussions became something that they started discussing at the time to see if they can also bring down the cost. And it's estimated that if that is really done, the cost can reduce very significantly. So I looked at the African sub-region to see which countries have NHIS coverage for kidney treatment. And when you look at West Africa, Ghana, Nigeria, Senegal, of course, they say out of pocket, but we know that recently there have been some changes in our country, so this data may change. And the transplant, there's no coverage at the moment, or I hope that in the future it will be considered as it is more cost-effective in the long term compared to hemodialysis. East Africa, Kenya is offering 2 sessions a week in public sector. Ghana can also do the same. They are not covering transplants yet. South Africa, they are covering dialysis treatment in public sector, transplant treatment in public sector as well. So South Africa has the most comprehensive public renal care system currently in Africa. Ghana can do same. I believe that. In North Africa, again, Egypt, Morocco, Algeria also cover dialysis mostly in public hospitals and cover some transplant to some extent as well. And Egypt has one of Africa's best transplant programs in Africa. Ghana can do similarly. We can adopt strategies that are suited for our situation in Ghana and also offer some support to our patients. Cameroon, even though it's stated here that they are not covered, I was in Cameroon recently, this year, and dialysis is subsidized. In Côte d'Ivoire, dialysis is subsidized heavily, not just subsidized heavily. If what I'm hearing is true, they are paying only $2 per session for dialysis. Yes, so Ghana can do similarly. I believe that. So kidney transplant in the long term is more cost effective. Quality of life is better. Life expectancy is much better compared to dialysis. So I believe that for our young patients in Africa and Ghana for that matter, kidney transplant is probably the best treatment for them. So most of them should be detected early, worked up to be in a program where they can be picked up on time and even get transplant without having to be on dialysis, or even if they go on to dialysis, they can transit safely to a transplant program. It's key and very important to cut down cost nationally and on households. So I looked at comparative cost, transplant versus dialysis. So this is data from the US. If you look at the initial cost of transplant, about $75,000 roughly. As I said, it can be up to $250,000 earlier on. But subsequent cost annual
For that and light cost implications of developing. I guess after this lecture, would all agree that prevention is the most cost-effective approach to actually kidney transplant. So we rather prevent than get to that stage. I will then treat us all to note down our questions. After the second lecture, we would have a Q&A session just like we did yesterday. So we'll proceed with our second lecture, and this would be delivered by Dr. Jumoa Edu. Dr. Jumoa Edu is a consultant nephrologist who, after a career at the Queen Elizabeth Hospital and a senior clinical lecturer at the University of Birmingham, England, returned to Ghana in 2009. He is an honorary consultant nephrologist and a senior research fellow at the Kolebu Teaching Hospital and the University of Ghana Medical School. Dr. Edu's research interests focus on immunopathogenesis and treatments of glomerulonephritis. I hope I got that right. And the genetics of chronic kidney disease. He's the co-PI of the H3 Africa Kidney Disease Research Network, which was funded by the NIH to study the genomics of chronic kidney disease in Africa. And this is a network of 15 academic centers in Ghana, Nigeria, Cameroon, and South Africa, together with other sites in the USA, Canada, and Israel. Data from that study has shown an association between variants in the apolipoprotein L1 gene and the risks of developing chronic kidney disease. And I'm sure Dr. Edu will share some data with us. So with a round of applause, let's just welcome Dr. Edu Jumoa. Thank you.
Thank you very much for that introduction. Vice-Chancellor, Provost, Deans, and Professors, colleagues from other doctors, ladies and gentlemen, on all protocols duly observed. I would like to discuss with you the management and treatment of kidney diseases. We mentioned the H3 Africa Kidney Disease Research Network, which has really funded our studies over the last 15 years. And as usual, with all these studies, there are very, very many individuals who were involved in the studies, and I listed them, some of them here. I do have investigator funding from Vertex Company. So I'd like to actually show some slides of the College of Health Sciences. This is our research office at the College of Health Sciences. This is a subject being reviewed at Kolebu Teaching Hospital, and I'm really very fond of Kolebu Teaching Hospital. It's a beautiful hospital, and I really admire some of the vegetation there. And if you're unwell, if you're ill, to have a view like this from your window, I think has a healing property. And then we're associated with Noguchi Institute of Medical Research, where we have a laboratory. So I think the University of Ghana is a wonderful institution. The College of Health Sciences, Kolebu Hospital. I've been associated with Kolebu Hospital for 50 years, and I really have enjoyed it, not continuously, I've really enjoyed my association with it. Now, what I want to do very briefly is to try and answer several questions. What do the kidneys do? And I'm grateful to Professor Boyma, my colleague, because he's answered many of these questions. What is chronic kidney disease? How do we measure kidney function? How common is chronic kidney disease in Ghana? And why is chronic kidney disease more common in Ghanaians as compared to Europeans? And then causes of chronic kidney disease in Ghana. How do you know if you have chronic kidney disease? Diagnosis and then treatment. So, as Vincent mentioned, African Americans are 3.7 times more likely to have chronic kidney disease, end-stage renal disease, as compared with European Americans. And this is largely due to variants in, I'll mention a gene, apolipoprotein L1 gene, which originally developed to fight sleeping sickness, but 10,000 years ago, but now increases our risk of kidney failure. And these variants originated in West Africa and unfortunately transported with our brethren in the Americas because of the slave trade. Most patients with chronic renal failure in Ghana, end-stage renal failure in Ghana, are aged between 29 and 59 years as compared with the UK and UK, where they're much older. And again, Professor Boyma mentioned that. So hypertension is a common cause of chronic kidney disease in Ghana, followed by chronic kidney disease of unknown etiology, and diabetes has been less common. As with other parts of sub-Saharan Africa, almost all patients with end-stage kidney disease, renal disease, are untreated and die from their disease. And this is something that Professor Boyma and our nephrology colleagues have been working to address. So the kidneys, as you know, Prof. Poimer, I'll just flip over this. So the kidneys, if you have kidney disease, you have accumulation of waste products, you have a high blood pressure, you have anemia, and if untreated, ill health. And again, we measure kidney function by a test called a blood test for creatinine and a urine protein test. What is chronic kidney disease? So again, chronic kidney disease is when your kidneys progressively fail. And we categorize that into stages from 1 to 5. And if you get to stage 5, then you need dialysis or transplant. And again, I will, courtesy of the late Professor Planjuru, who did a lot of work on kidney disease in Ghana. Sorry. Again, the prevalence of chronic kidney disease is around 14%. And the major causes of chronic kidney disease in our environment are high blood pressure and then diabetes. And Africans, as I've mentioned, have these genetic variants that increase the risk of kidney disease. And again, this is shown here that hypertensive kidney disease accounts for 39% of individuals with chronic kidney disease, and then also unknown causes of chronic kidney disease account for about 28% of kidney failure. Again, there are environmental toxins, and some people have been assessing basically the way that we've contaminated our environment, partly by illegal mining, galamsey, and also by use of pesticides and so on in rural areas. And this has become a major problem in Ghana. We haven't studied it in any great detail, but it's something that we need to have a look at. And they found significant mercury contamination, and these are in rural areas, lead contamination in the soil, cadmium contamination, and arsenic contamination in our environment. And these are all causes of chronic kidney disease, kidney damage. So it's significant, yeah. So our ancestors, as we mentioned, developed a gene that protected them from dying from sleeping sickness. That was a very lethal disease about 10,000 years ago. And so the ancestors, those who had this APOL1 variant, which is found in a quarter of Ghanaians, survived. So individuals survived because they had this gene variant that protected them from dying. And this gene variant, 10,000 years ago, significantly increases our risk of getting kidney failure. And this is just a brief overview. So if I can show you, these are the organisms of sleeping sickness, so-called trypanosome. And the gene that actually protected our ancestors against sleeping sickness now increase our risk of kidney failure. So it's an unfortunate consequence of evolution. And Professor Poema has shown in this form, we studied about 10,000 individuals with kidney disease and found that 29% of individuals with kidney failure had APOL1 variants, and this was an important cause of progression to kidney failure. So the APOL1 variants are a very major cause of chronic kidney disease, and they're found in about 30% of Ghanaians. So, and we reported this back in the New England Journal of Medicine last year. So most patients with chronic kidney disease, or most people with chronic kidney disease, do not have any symptoms until the disease is far advanced. So the problem can only be detected if you do blood and urine tests. And the symptoms are minor: swelling of the ankles, feet, and legs. Later, loss of appetite, nausea, vomiting, high blood pressure, and an anemia, which can cause tiredness. But the symptoms are very minor and really not very major. I've discussed how you detect kidney disease, that you do a urine test and a blood test. And the urine test will usually show protein in the urine, and the urine test will show protein in the urine, and the blood test shows a high level of creatinine. So, how do we treat chronic kidney disease? I think about controlling the blood pressure using drugs called angiotensin blockers. Good diabetes control. Good diabetes control, avoiding painkillers such as anti-inflammatories. Diclofenac is an example. Avoiding herbal remedies and lowering the salt in your diet. So in diabetic and non-diabetic kidney disease, the following slow down progression. Treatment of the hypertension using drugs called angiotensin blockers. Using treatment of drugs that were developed for diabetes initially, but block glucose absorption by the kidneys. Forxiga is an example. Again, will slow down progression of kidney disease. And aldosterone receptor blockers, again, can slow down progression of kidney disease. So we can slow down progression. I asked the question, can we slow down progression of kidney disease, chronic kidney disease? Yes, we can slow down progression of chronic kidney disease with good blood pressure control and treatment with angiotensin blockade, SGLT2 inhibitors, and aldosterone blockers. So what are we doing to reduce the progression of chronic kidney disease to end-stage kidney failure? We have been doing a study of a drug that blocks the protein that the APOL1 gene makes. So APOL1, if we block APOL1, we can slow down progression of kidney disease. And so we're doing a study of individuals aged between 12 and 65 with non-diabetic kidney disease and proteinuria. And this drug, we hope, will prevent individuals developing progressive chronic kidney disease. And we are halfway through the study. So if you have chronic kidney disease and are non-diabetic, you can ring our research coordinator at that number 0501871631, and I have permission from the Ghana Health Service Research Ethics Committee to request individuals with chronic kidney disease to contact us. Again, we've done a lot of community engagement to try and get what's known about kidney failure to individuals in the community. And this is ourselves at, we went to Cape Coast Town Hall, and we informed individuals about the causes of kidney disease and how they can protect themselves. And this is again me and Dr. Osafo, my colleague at Domi Market in Accra, again to talk to the elders about chronic kidney disease. And this is a patient of mine who actually started me on this journey. She had kidney failure and her uncle had kidney failure, and she told me, why did you not tell the community that if their relative had kidney failure, then you should, they should tell their relatives to get themselves screened. And she wouldn't let me go. She just fixed me and said, why are you not telling individuals about the risk if their relative has kidney failure? And she, in a sense, got me started on the journey. So, in terms of prevention, we've got to identify, and I'm making a recommendation for Ghana, identify potentially healthy subjects, apparently healthy subjects, and then inform them, educate them so that they can avoid developing chronic kidney disease, and early detection and impaired kidney function with proteinuria and progression can prevent progression of kidney disease. And then 2, we need to build prevention studies that are national and that reduce the progression of kidney disease. We need to educate health workers and encourage community participation. We need to establish a national screening program for chronic kidney disease. We need to implement treatment protocols for individuals at risk of getting chronic kidney disease. We need to train healthcare workers to implement these treatment strategies. We need to develop community engagement strategies to educate the public about the risks of obesity, salt intake, hypertension, diabetes, leading to chronic kidney disease. We need to establish hemodialysis units in all the regions in Ghana, all regional hospitals. NHIS, I would recommend, that pays for all patients needing dialysis. They can pay for 2 dialyses, and for example, as Vincent has shown, Kenya has, pays for 2 dialysis sessions in individuals with kidney failure, and expand current renal transplant programs. We've had a transplant program since 2008 at Kolebu, and Dr. Bernard Morton and Dr. Osafo first initiated that. And we've been doing live donor kidney transplant programs, and we now have an independent transplant program, and we're trying to get legislation so that we can have cadaveric kidney transplants as well. We've been training doctors and nurses since 1991. The Ghana Kidney Association has developed, organized regional training for doctors and nurses. We've developed subspecialty training in nephrology in Ghana, and one of our first graduates was Dr. Ochre, and she's now at Konfanochi. And then we've also developed subspecialty training for nurses at the College of Nursing. When I say we, it has been developed. The Ghana Kidney Association has established a renal registry so that we know the numbers of individuals that are needing dialysis. And this was led by Prof. Boyma. The Ghana Kidney Association has also developed a national framework on chronic kidney disease for discussion with the Ghana Health Service. In my conclusion, the prevalence of chronic kidney disease in Ghana is around 14% of adults. Most patients with chronic kidney disease are young, between 29 and 59 years. That's compared to the UK, where they're 60 to 90 years before they develop chronic end-stage kidney disease. Hypertension is the most common cause of chronic kidney disease, end-stage renal disease, followed by unknown causes. As with other parts of sub-Saharan Africa, most patients with end-stage renal disease are untreated and die from their disease. I would recommend that we implement strategies to reduce the incidence of and progression of diabetic and hypertensive renal disease, as this will have a huge impact on life expectancy, the quality of life, and cost to society and healthcare payers. It is imperative that kidney specialists move what is known about the prevalence and prevention of chronic kidney disease into the community. It's not just enough for us to know about it without letting the community know. Thank you very much for your attention, and I'm really grateful.
Thank you, Dr. Edu. Let us give him a warm round of applause. Thank you. Distinguished guests, it's been a privilege to listen to insightful and thought-provoking lectures. And what is clear from these lectures is that after 25 years as a college, the College of Health Sciences is not only asking questions, but we are taking steps to provide answers that would shape the next generation of healthcare in Ghana and beyond. It's now time for questions and answers, and I kindly ask that we keep our questions brief and to the point so we can hear from as many voices as possible. And I'll kindly invite Professor John Ganley from the School of Public Health to moderate that session. Prof. Ganley, welcome. Thank you.
So if you can have our guests go up stage again while we start the Q&A process, please. And I think we now need 2 more microphones. Sorry, I think we need 1 microphone for them. I brought 1 here. Okay, cool. All right, so please, if you have a question, I think we would, Chair, with your permission, we'll take like up to 3, and then we can come back for them to respond.
Okay, so thank you very much for the opportunity. Yes, I really enjoyed the lecture from both Prof and Doc. My question is on when I saw one of the slides from Dr. Edu on avoiding herbal remedies, and because I have a soft spot for herbal medicine research, I began to ask myself that Prof. Boyema is talking about us saving costs, wastage of resources, and also producing some of these consumables in Ghana so that it will be cheaper compared to the amount we are spending now. So I want to find out, is it all herbal medicine? Because now we are looking at how we can use the things we have in Ghana, the plans that we have to provide some of these interventions instead of maybe going abroad to purchase some of these drugs. So why don't we look into it? Because I know we have a research center in Mampon and other places that are looking into herbal medicine. So if you are avoiding herbal medicine, don't you think that the cost will be too high for us to bear? Thank you.
All right, thank you, distinguished lecturers. My question is, we have grown hearing so much about caffeine consumption, alcohol, and not drinking enough water as risk factors for kidney problems. But as a member of the public, I haven't heard much on that. Are we toning down emphasis on that, or is it still valid, or is it necessarily because those may work through the mechanism of hypertensive disease? Or if you can hear a word or 2 on that. Thank you.
Thank you so much. This one goes to Professor Boyema. Yes, I know you are working on a bill. You are part of a team working on a bill for organ donation in Ghana. Yes, and we are talking about kidney transplant. How far about that bill? Thank you.
Okay, thank you. So maybe we can take these 3.
So thank you very much, Mr. Ankama, for the question. My boss here should answer, so I'm answering. So it's good to actually cut down cost by producing things locally. I agree to that. Of course, I mentioned that a lot in my presentation. And of course, mention the fact that we need to produce drugs locally is not a bad thing to think about or to say. It's good. But the drugs produced must be safe for consumption. And scientists in this room, as you all are, would agree that when you take one herb, there are so many active ingredients in that herb. So the herb has to be taken, and the active ingredient that is probably meant for a particular disease condition should be extracted and tested to be safe for consumption. Not us going to the bush and taking the whole herb, grinding it and consuming it in whole. That way we are consuming both what is good and what is bad. And the kidneys as they are, everything, almost everything you drink will probably go through the kidney. So the kidney is exposed to a lot of the things we consume. So imagine you consume all these toxins along with the active ingredient you want for malaria, for instance. The kidney is exposed to all these toxins. Over years, you're going to have kidney injury. So we're not saying do not use the herbs or the locally available whatever it is to produce medicine. It must be produced safely for consumption. It must be tested to be safe. It is important. Yes, I agree. But is it safe for consumption? And most people who are doctors here who have worked in emergency rooms would attest to the fact that we've seen increasing numbers of people with acute kidney injury in the emergency room from herbal medication use. And some of them have come down even with breaking down of their red cells, their jaundice, their kidneys have shut down acutely, etc. It may appear as if not all of us are predisposed to this kind of thing, because somebody will say, oh, I've been doing this for years, I'm still fine. But some people are predisposed. That also shows the individual differences for all of us. Some are more predisposed to having problems when they use it than others. So the risk must be weighed against the benefit. In the interim, do we have the capacity to produce drugs this way? That's the question I want to ask. Thank you. So about the legislation. So yes, transplant requires legislation because we need to increase and develop our transplant program in Ghana to include other forms of kidney donation, which will include disease donation, for instance. Currently, we're only doing living donor kidney transplant purely because we do not have legislation, as Dr. Edu would say. So the legislation is key when it comes to expanding and sustaining our transplant program into the future. And therefore, thankfully, Dr. Edu and then our predecessors, Prof. Yeboah and co. have actually developed a document which was supposed to be used for the legislation. And we, the Gen Zs, came to meet it. I'm a Gen Z, I don't know. We came to meet the document, so we've taken the document, and then the document is currently at the ministries. We would say we have made progress because we are now communicating very often now with the ministry regarding this particular document. I can see hopefully some light at the end of the tunnel because we have all the stakeholders on board now discussing it. And the minister is actually pushing it. So we hope very soon it will go to Parliament. In fact, they are not interested in approving only the kidney transplant legislation. All legislation regarding every kind of organ transplant in Ghana are being considered. So from the obs and gynae, fertility people, but Dr. Promise is there, he knows about it. The cornea, the eye people, they are all involved. So we are all trying to move at the same time to Parliament for the bill to be passed. That's where we are now. Thank you. Thank you.
Yes, caffeine.
The caffeine. So caffeine, alcohol, and water intake. So caffeine, I haven't really come across any study that clearly says that caffeine causes kidney disease. We know about things about heart disease, arrhythmias, maybe BP, etc. But I don't have any study linking caffeine directly to kidney disease. So I'm unable to give you more information on that. Excess alcohol maybe, because excess alcohol and the risk of heart disease, heart disease can cause kidney problem. Excess alcohol, the risk of atherosclerosis, and its implication for kidney disease, etc. That's probably where I will link it from indirectly. And the reason for me, one thing that is really keeps crossing my mind is the Appiah in our environment. Like the Appiah it contains a lot of methanol. And the methanol is not healthy for the body. It's toxic. but we are consuming this in large amounts. That can probably be a potential reason to say maybe there's kidney disease, because it increases your risk of kidney stones, etc., and all that. And so the local gene acquisition per se has to be studied and see if it is safe for our kidneys or not. About water intake, our nutritionist, professional nutrition, that addressed this very well yesterday about water intake. Nobody is saying that we should drown ourselves with water. Adequate intake of water is what everybody is requesting for. Mind you, excessive water intake can also lead to water intoxication. So, water intoxication, or actually estimating a certain person of a certain body mass. Okay, thank you.
We do have some questions online. There's a whole lot of people online, so maybe I'll read those ones out while we wait for questions on there. So the first one is got to do with paracetamol use. So somebody's asking, this is something that is commonly prescribed, but also you can get over the counter. What is the long-term effect of paracetamol use on kidney health? Paracetamol, yeah. And maybe this one is probably for everybody from the college. So the person says one of the popular cocoa beverages has like 40 grams of sugar inside. So the questioner is asking, as a college, so because it's mentioned almost all the schools, pharmacy, everybody inside, what are we doing, or what can we do to save the public from such products? So that's why I said it's probably for all of us from the college. I do have two questions, one for Prof. Boima and then one for Dr. Edu. So you've spoken about the tax issues, and I wanted you to comment on, if, for example, we're asking for tax reduction, do you think it should be across board? So when I say across board, private sector, public sector, and depending on what you choose, what would be the distributive effect of that reduction? Dr. Edu, you've implicated a very specific gene in the African population, and I just wanted your thoughts on whether there is possibility for example, gene therapy, gene editing, to probably help in lowering the risks. I don't know what the science is now, but is it possible we can probably, since we know that a specific gene at least increase the risk by almost 30%, is that possibility for us to use gene editing to do that? So maybe we can take these four and then we come back to the audience after this. Thank you.
Okay. Perhaps I'll start off by answering the question of whether paracetamol can cause kidney damage. Ordinary paracetamol in doses of up to 3-4 grams a day for a week does not cause kidney damage. So it's safe. It's a safe painkiller in that respect. And in terms of, it's safer than anti-inflammatory, non-steroidal anti-inflammatory drugs. And I won't mention names because they think I'm bad. But when you have pain and you go to the pharmacy, ask them for paracetamol and not for NSAIDs, we call them for short. If you take an overdose, individuals who take an overdose poison themselves with paracetamol, then that is often associated with kidney failure. But in terms of 2, 3, for paracetamol because you've got a headache or some, period pains. It does not cause kidney failure. Yeah. Again, there was a question about sweetened beverages in cocoa, whether that specifically is associated with kidney damage. And the answer is no, unless you become diabetic from an excessive amount of sugar, and then it will take 10 years or 15 years for you to get kidney damage. So taking cocoa as a drink itself does not cause kidney damage.
So my question is on the tax and cutting down cost and all that. So import duties, VAT, etc. I believe the ideal thing would have been private and public. I believe so. But can we afford? Can the government take the load? Now we can learn from Kenya, where they are sponsoring only the public sector for now. We can learn from South Africa, where public sector is being supported. South Africa, actually, what they do, if I can touch on it a little bit, is that if you are with above a certain salary bracket, you are encouraged to seek care from private sector because you can get insurance to pay for your health care. When you are below that kind of salary bracket, you go to the state hospitals where you get treatment free. And in the state hospitals, again, because they can't, they've realized that they can't pay everything for kidney replacement therapy, they've also put in certain kind of protocols that will select people who are potentially useful or beneficial to society, per se. So, for instance, if you are transplantable, and there is no contraindication that you will get transplanted, then you will be accepted in a state hospital onto a kidney replacement therapy program. And the end result is that when you're on dialysis, one day you will get a kidney transplant and exit. So that probably will reduce cost for them. And that's seemingly how they are trying to manage their cost in their country. And like I told you, in some other countries nearby as well, they are not short of paying a token to cover cost, maintenance cost, etc. I told you that in Cameroon they are paying $2 per session, Cote d'Ivoire they are paying $2, but all these are being done in public sector. For instance, in Cote d'Ivoire, what happens is that when the program in the public sector is full, so they have caps on it. So you can say, Kolebu, okay, you can dialyze only up to 200. Government is going to pay for only 200 people. So when you get to 200, they will stop the program until a space becomes available. Then somebody else can jump on board. So everybody else who is not able to get into a state hospital will now have to go and queue somewhere and wait, and be dialyzing in the private sector and wait on the queue until they call them and say, oh, now space is available, you can come. So that's how they are managing their cost. We can develop a strategy that is suited for Ghana in a way that we are able to afford and carry the burden. That's what I think we can do. I wouldn't say we should just start by paying for public and private. That probably may be a problem. I don't know what Dr. Edu has to say about it.
No, I won't go there, but I will talk about the gene that, the APOL1 gene that makes a protein that damages the kidneys. And actually, we've got a study going of a drug called inaxaplin that potentially blocks the protein function. And so we're doing a trial of that drug in individuals aged 12 to 65 who have non-diabetic kidney disease. And that's why, I gave the first drug that's being tried to block that APOL1 gene. Thank you.
Can we take more questions? Okay. Yes, please.
Thank you for the insightful lectures. My first question is to Dr. Edu. You mentioned a drug trial to slow down progression to end-stage kidney disease. And you also said that diabetics were excluded. I just wondered why you excluded diabetics. Is it because the drug doesn't work for them, or because of confounding factors like diabetes causing its own kidney disease? And then the second question is, the gene that you mentioned, how is it inherited? Is it polygenetic or autosomal? And also I wanted to know whether some people who have the gene whether they don't express kidney disease. What proportion of people who have the gene don't end up having kidney disease? Whether you've studied that too. Thank you.
Okay, thank you very much. So my question boils down from the thought or the lectures we had, and also from my exposure to CKD literature. I realized that all the symptoms, the causes, all the things that we are talking about are things that are part of us, that we can't do away with them, especially the genes that you spoke about, and also the food, because most of the food we eat, especially in Ghana, comes from our lack of food. We created the food just as we celebrate some festivals like Herbal, Hooting Against Hunger. If you look at all these foods, they are starch-based, all the monosaccharides, disaccharides, and all the polysaccharides. So you can see that most of the foods that we eat are sugar, or at the end of the day, you get sugar. So why don't we focus our attention on maybe changing our diet in terms of creating food that has less of these starches, so that we can live longer? Otherwise, it seems like West Africans or Africans, we are supposed to die from these NCDs, especially with diabetes, hypertension, because if you look at the statistics, when you compare with UK, where you realize that people start showing these symptoms in their late 60s, but in Ghana, in early 30s, and also up to about 60 years, we start showing symptoms or get sick. So why don't we put our attention on the food, changing our diet, instead of maybe coming out with a bill on maybe transplant and others? So, thank you.
I'm Prince DeGrant Brempon from Auction Export. I want to ask that, are there certain foods that you can eat to prevent the disease, the renal disease? And also, are there risks involved during the period of transplant and when having dialysis too? And also, is urinating too much a cause of the disease, the renal disease? And is there a free screening program done in hospitals in regards to the disease, a free screening program?
Perhaps I'll answer the questions about the APOL1 gene and diabetes. Individuals with diabetes do not have an increased risk of kidney failure because of that gene. For some completely strange reason, if you have a high-risk allele and diabetes, you're not at increased risk of getting kidney failure. So that's why we've excluded them, because they're not going to get kidney failure from having the high-risk alleles. And you asked about the actual, what is it about the APOL1 variants that lead to increased risk of kidney disease. So these variants are amino acid substitutions, and they initially protected ourselves. They kill trypanosomes and sleeping sickness, so protect individuals against sleeping sickness. But these variants, quite why they cause kidney damage, is a subject of intense study. But for example, so we find that they maybe damage the podocytes, getting technical. These are bits of the kidney filtration cells, and so they damage them and therefore cause proteinuria, which then leads to kidney damage. So we exclude individuals with diabetes, not for any negative reason, but APOL1 variants do not increase the risk of kidney failure. Does that answer your question?
So, with the question about, so Dr. I think, sorry, she asked a question as well about the clinical trial and then the drug that we are testing. So there's the chance that if this drug begins to work, hopefully it becomes available and then can slow down progression of kidney disease. There's a publication already which shows that it worked in terms of reducing proteinuria almost by 47%. So it's possible that the drug may become useful in future. The cost of it may be the problem, but when we get there, hopefully we cross that barrier as well. So the issue about high-calorie diet and healthy lifestyle was addressed to an extensive extent yesterday by our professional dietitians. They talk about a lot of things that we should be eating healthy in order to slow down progression of kidney disease. They talked about vegetables, they talked about fruits, they talked about reducing your carbohydrate intake, they talked about reducing meat sources because of the uric acid that may impair kidney function, sticking more to white meat, etc. And all that was discussed yesterday. The experiences we have had in the consulting room when we are telling patients this thing, and I'm sure they also had their experiences. Once you mention this, the typical Ghanaian African starts laughing. It means that they are not ready to depart from their carbohydrate ways and then embrace these fruits and vegetable. So you talk about it and say, Doctor, where dear, etc. So it's an ongoing education, an ongoing thing. We need to continue pushing and see if people can change their lifestyle and of course eat healthy in order to prevent or delay progression of kidney disease. Environmental exposures are a lot. We are now poisoning our food from the galamsey, and therefore nobody is exempt from developing kidney disease. Don't think that I'm not in a mining area, so I'm safe. No, the food is being transported from all those areas to Accra, and we are consuming them. And there are indications that even the mercury content of the Wager Dam is increasing, etc., and all these. So we are not exempt, even though we are living in Accra. The chemicals are being transported through our food, and we are eating all of them and exposing ourselves to these environmental factors that increase our risk of developing kidney disease. There is definitely, or perhaps, an interaction between these environmental factors and APOL1 gene. As Dr. Edu rightly mentioned, that a proportion of people with the high risk allele do not have kidney disease, which tells us that perhaps there is a need for a second hit, like environmental factors interacting with these genes to increase the risk of developing kidney disease. Now we have air pollution, PM2.5. We have the chemicals, arsenic, mercury. We have various other environmental exposures. Every corner you pass here and then somebody is burning something, etc. What are the implications of all these practices especially when we are already genetically primed to develop kidney disease. These are things we need to take off. When I was a little child, today at Ghana College, I remember a little child, we had these people called a tankasifor. Aha, when you hear them coming, you sweep your environment very far, you drain the gutters, you weed your area, make sure there is no place for mosquito to breed, etc. But these days, everywhere you go, in fact, there's a gutter there, you see mosquitoes and etc. And I think that, I'm not saying the tankasifor should come back, but there should be a way of us keeping our environment clean, reducing pollution, reducing exposure to all these environmental factors that really are also adding to the risk of kidney disease that we are talking about today. Food to prevent kidney disease, we've already discussed it. Risk of transplantation, there is no treatment without risk. Even paracetamol has side effects. So every treatment will come with its own side effects and risk, definitely. However, you always weigh the benefit of whatever treatment you're offering against the risk that the patient is exposed to. Definitely, there's more benefit when you dialyze and remove the toxins to stay alive than the risk that you are exposed to. Same with transplant. The benefits that you derive by staying alive and getting your life back is much more than the side effects that you are exposed to. And most of these side effects or risks are things that are treatable and can be attended to for you to live and stay alive even though you are exposed to such risk. Urination is not a cause of kidney disease. Neither is holding urine for a long time before going to pee a cause of kidney disease, as is a myth out there. However, frequent urination may be a sign that you are developing kidney disease, especially when you wake up too frequently in the night to go and pass urine. It may be a sign that you may be developing kidney disease. Free screening programs. Well, I'm not sure of any free screening program currently in Ghana, but I know that in the various primary care centers, we have chronic disease clinics, hypertension clinic, diabetic clinic, sickle cell, etc. And we have wellness clinics as well. Now, by way of policy, we can institute screening programs into these various clinics so people can be detected very early with timely interventions to prevent or delay progression of kidney disease. For screening and free advocacy, free screening, free advocacy, I hope it would come with time. Thank you.
Right. Thank you. I'll just continue from where you ended, Prof. Wema. So most of the factors are environmental. From Dr. Edu's presentation, where you're talking about screening. Yesterday on the road, I thought a car caught fire. It was just from an exhaust fume, and we are breathing all this. You've done a wealth of work over the decades. I think we probably have enough data to start thinking about policy. I just want to hear what you have in mind. You have to fight hard to get the ears of our parliamentarians and ministers to talk about screening and all that. Just the policy part into action.
I was with Dr. Edu at the Ghana College today where they are doing a medical knowledge fiesta. And they are talking about climate change, environmental factors, and diseases in general, not only chronic kidney disease. And somebody asked a question regarding the recent Galamsey and declaration of emergency, state of emergency, to actually work on this to prevent more people from dying from all kinds of diseases. The response from the person who was sitting there is that the threshold for declaring a state of emergency is subjective. So meaning it's a gray zone, and they live in that gray zone, whether they really would come to a point where they would take the decision for a state of emergency is subjective. It's a problem. So I approached this guy after the meeting and I told him that, look, if you don't make a decision and you say it's subjective, you remain in that gray zone, you will never take a decision. So that is where we are at the moment. We need political willingness to declare a state of emergency regarding environmental exposures that really increases our risk of developing non-communicable diseases. We know the burning that you mentioned, air pollution, increases your risk of hypertension, diabetes, insulin resistance, etc., and kidney disease, of course. And all these are things that we can come up with policies regarding where people should be burning things. Everywhere in Accra, you see people burning things, etc., which is really not healthy for us. So that I don't know where the policy is going to, or whether it's going to come or not. I know there are people in policy here who probably will want to answer this question.
I think they go to the police hospital and check if they have this prevalence of kidney, whatever disease. You know, traffic light not working, you are standing there directing traffic early morning, breathing all this. And then when they hear this, they will do the fighting. I mean, I don't want to go and stand in direct traffic and die by 60 years, 45 years. So something very concrete and frightening. We know our men, when they hear this, then they come running. Other than that, it's just going to be on paper. Thank you.
Dr. Edu and Dr. Edu actually put a grant together for environmental factor, climate change, and kidney disease. We didn't get a grant, but what I wanted to say is that U.S. grant, NIH is drying away. And therefore, as a nation, we need to develop a state funding kind of scheme for research in Ghana. So that has to be key in order to fund research that will come up with findings that will support policy. So we need stakeholder policy makers to work on this. Mr. Provost.
Sorry, do you want to?
Okay, my question is, I want to understand why the 28-point-something% of patients with the kidney disease, you don't have reasons for that.
That's a known cause. So unknown cause.
So it's
who don't have any cause for kidney disease.
Yeah. Okay. Let me just add this last one, and then so you can box it together. So Bernard Opong is wanting to know whether there's a correlation between the orthodox medication for managing hypertension and diabetes and CKD. So he wants to know whether the usual medication we would give to a hypertensive patient has any link with CKD.
So what was the other question?
CKD for known origin.
Yeah. Thank you very much. That's an important question. So undoubtedly there is a cause, but we haven't identified it as yet. So I think many of those individuals will have, actually, it's a very important question, because in the UK, for example, where I practiced for many years, almost 90% of individuals, you do find a cause. But there are, in Ghana, we do find individuals who come in with end-stage kidney disease, and you ask them, and they have no history of having had any illnesses, previous illnesses. And as I said, that's unusual in other parts of the world. So quite what the explanation is for that, we don't know. And Prof. Boyma and I have been doing a lot of research to try and find out why an individual of 25 with no illnesses will come in with advanced kidney failure.
So in that case, what do you do for those patients?
Unfortunately, we just put them on dialysis. So we just put them on dialysis. If they have end-stage kidney failure with no obvious cause, then you need to treat them with end-stage treatment. What's the other question? Oh, no, in terms of the drugs, again, one of the things that I wanted to go emphasize is that mostly individuals with high blood pressure will be put on nicardipine, and that was from a study way back. There's a doctor called Lara, way back in the 60s, who found that African Americans responded quite well to nicardipine type drugs, and we developed that in Ghana. But actually, mostly, they're useful as adjunctive treatment, but usually, mostly, individuals should be put on angiotensin receptor blockers or angiotensin inhibitors because they protect the kidney function. So it's really very important. And I had some questions that I didn't have time to address, that the current treatment for high blood pressure that's recommended in Ghana does not protect the kidneys, and individuals need to ask their doctor, why am I not? You say I've got kidney impairment of my kidney function, why am I not on angiotensin blockers? And I had those questions. It will make you popular with the doctors, but we should be using more angiotensin blockers and fewer calcium nifedipines and nicardipines in terms of kidney protection.
Okay, thank you very much. I think we can give our speakers a round of applause and then also ourselves. And I would hand over to our MC to take us to the final end.
Thank you, Prof. Gandhi, and thank you all. We've had an engaging session. I think we've built on our theme, eat or not to eat. Now we have drink or not to drink. So thank you, colleagues, friends, for staying with us, and our online participants for staying with us. At this
speakers, both today and yesterday. Our special guests who have joined us both in person, those who have tried to join us in person, those online, I realize we have quite a number of people who join us online. Our esteemed staff, hard-working staff, our students, our alumni, and all our friends of the College of Health Sciences. On behalf of the committee that put this together, which is the College of Health Sciences Biannual Scientific Committee, who helped us to put this together. It's especially selected because we know that this one, we touch on a very special health issue that is very, very dear to many families. So we are very grateful. And on behalf of the chair, Professor Andrew Sajay, who unfortunately couldn't join us because he was bereaved. I know he was watching us online. So, Prof, we extend our condolences to you and your families. We are very happy that you were able to put this together. As you heard from the speech from the Provost and our chair for today, the Vice-Chancellor, the College of Health Sciences is 25 years, and as the 25 years, we are the pioneers of the collegiate system. And of course, it's not a surprising thing that we did, because at the inception of the establishment of the medical school, this idea was already there. And the reason behind it was that we wanted to train all the medical professionals under one umbrella. It will save us costs and so on. So for our past leaders ensure that this come to a fruitful. That's why the college was established 25 years ago. We've done so well. We are a pioneer. And the management of the college decided that we have to celebrate this in a very moderate way. And that's why we have put so many things together to ensure that we manage to celebrate this to Or just to tailor it to what we have been doing as an excellent center. The college is very diverse, but we know that even all the health professionals that we train will end up working together. So if you train them together, they start learning how to work together, and together we can have this. We've done well over the past 25 years, and the college has trained many people. We have all our alumni across all the facilities, all the health facilities across the country. So we've done very well. So it's good that we celebrate this. We put this together, and the theme was that we proposed the team, College of Health Sciences at 25, transforming life through excellence in education, research, and healthcare. And we have done it very well. We educate the public. If you look at the team we selected for this, it's very dear, and I'm sure you have learned for the past 2 days a lot of things from here. We pick so many things. You pick some for yourself, you pick some for your family, you pick some that you are going on to educate others on. Our aim was to educate the public, and this is a very dear topic that we pick, and I'm sure we have all enjoyed listening to it. We have picked something from it. As we decided to celebrate it for the whole year, we started in May. We put out so many activities to mark us. Even last week, we met as a family to exercise and bond. So we were together, we left our offices and our classrooms to meet and then also have some fun. So this is continuing. Next month is a breast cancer awareness month. And as part of our activities and champions in the health sector, we are going to have another symposium, and that will talk about breast cancer and also cervical cancer. So these are part of the activities that we have lined up. In November, we'll climax our activities. And in climaxing the activity, we have put so many things together, and we encourage you to look at our timelines and then try to join us. We'll have a conference, and the conference will be led by one of our Center of Excellence, the Gucci Memorial Institute for Medical Research. So far, they have received over 350 abstracts showcasing the science, the research that they're doing in the college. And we encourage you to join us. To come on, the date will be announced very soon, but this will be around 25th and 26th of November. And before that, we'll have a dinner night where we try to raise funds for the college, and we encourage you to also join us. The date will also be what we call the...
Before we move to, so we've got presentation of citation to our retirees, but his closing remarks before we do the presentation.
Thank you very much. I look forward to your dinner, and I'll be looking out what you serve. And on that day, I'll bring a CCT camera and identify those who decide to eat or not to eat. For the past 2 days, we've gone through a 2-day of lecture, which is very, very important. And as I sit here, I was even afraid, moving around. What do I eat? What do I drink? Is it too much? Is it? And you see, and they said if you drink too much water, it's good. So I was sitting here. I went to the washroom and so I was like, so is it because I went there? So I'm drinking too much water. But I think the key word is moderation. I'll say for the past 2 days, we've looked at what the kidney is and how to keep the kidney well nourished till the kidney decides to break down, and what to eat or what not to eat. Identify, I'll call the value chain of the lifespan of the kidney. Yesterday we looked at the things we need to eat. We looked at 2 clinical cases that confirmed or showed that with a lot of effort with your medication and nutrition, there'll be improvement in your kidney diseases. Today we've looked at the costs and how to manage it, and manage it at various stages. For me, coming as with economics background, I mean, the cost is dear to my heart. I realized that the indirect costs of to eat or not to eat is a huge burden on society. The treatment of the disease from the presentation is not too much of a cost. The indirect costs, the caregiver, leaving your work. For you, the patient, you have to forgo your work. The caregiver also has to forgo his or her work. When you put those two together, it's even more than the cost of treatment. And if you have to do this over a year, then there's a big concern. And I think this calls for deep collaboration with other disciplines and with social science. Now we know the science of it. We know the science. We can tell the public the science. But what we need to change is the behavior and what happens in the community. So, College of Health Sciences, please look out for the social sciences. We need to do a very, very detailed costing to appreciate the indirect cost. Because for policymakers, you need to put figures. As for the story, when you tell them, they will listen, because when the sickness catch up with them, the Article 71 holders, and whatever needs to be done, it will be done for them. But for me and you, there's nothing to be done. So I think let's talk and see how best the indirect cost, the cost of caregiver and other things, we can put cost to it so that we can tell the full story. We've gone through the symptoms of the diseases, how we can treat or prevent it, how to slow down the progression, and the other issues that comes out of it, issues of research funding. I mean, we're in a country where all this research that has been done is not funded by a taxpayer of Ghana. The only thing that the taxpayer has paid is maybe the salary of the PI. But we need to get to a stage where, as a country, we fund this research. At times, be responsible for research and innovation, and colleagues come and USAID funds is cut, NIH. At times I say that, well, maybe they've done enough. We as a country, if we had counterpart funding to support NIH and USAID funding, the cutting of the funds, there will be no impact. There are quite a number of projects at Noguchi and other units where the funds have been cut and work has to stop. Why? So we need to ask those questions to our policymakers. And for the recommendation that government should support it, I don't think it's difficult. I mean, if we go on strike today on book allowance, tomorrow it will be paid. If we go on strike that we should increase salaries, in 2 months, there will be an adjustment. Maybe we all need to come together and be on the street for government to appreciate this. I mean, our parliamentarians, we have 265. They all have V8. And we've used taxpayers' money to buy it for them. Our parliamentarians, they've all been given rent allowance. And we've used taxpayers' money to pay for it. So what it means is that we, as a country, we need to prioritize. If we don't prioritize, we'll all become MPs so that we get a V8 and housing accommodation for free. That's the taxpayers' money. And then the majority of Ghanaians will suffer. So I think we can do it. And I plead with policymakers, or whoever in authority. I'll be told that I'm also part of the authority. But for everything, there are different levels. The higher levels, I think we can do it. We need to prioritize. It's just like our roads not being good. If we had prioritized, the roads would have been good. If we prioritize and we decide that whether you are a state official, if you are going to Kumasi, we all use the road. If our roads will be in good state. So I believe we can do it, and we need to insist on it. In all this presentation, societal costs, economic costs, environmental costs comes out very, very clearly. And we, as citizens, face that cost, and we have to pay for it. Okay. I'm hoping that for those who are listening, we all have a responsibility. I realized that the questions that were being asked were a little selfish. People were looking at what they are doing and how they can deepen it, even though they've heard that maybe it's not good, but trying to make a case. I think we all need to let go what our daily bread is, or where we get our daily bread from, and concentrate on how we will stop this. We all have kidneys. We will all grow. We will all get to our 60s. And if we need to take a decision to slow this kidney disease, it should be now. College of Health Sciences, I don't know what we can do. But for me, responsible for research, I'm happy for ideas. We need to get funds. We need to support the research that you are doing. I'm also open. Let us discuss and see how best, as a university, we can support this. And I'm sure if we take only the kidney and decide to drive it as a university, we will solve a lot of the sicknesses in the country. As I listened to all these issues and I reflected on our research priority as a university, we have 7 areas. The first is infectious and non-communicable disease, where the kidney falls directly. We have food production and processing. We have transdisciplinary research into climate change, development policy, poverty monitoring and evaluation, the politics, sociocultural change, creative arts, education, communication, and then the 6th is the 4th industrial revolution area. To eat or not to eat, the issues that we've raised I can identify research questions in the 7 priority areas of the university. I mean, we are talking about advocacy. We can find something in our priority areas. We are talking about food processing and food production and processing. It's also in our priority. Climate change issues came. It's in our research priority. Issues of poverty, monitoring and evaluation, it is in it. Somebody will say 4th industrial revolution tools, where we talk about data science and other things. The data that you are collecting can be subjected to big data analysis. And some of the nuances and some of the things that we cannot quantify, the big data analysis can help us. So I will encourage the college that we approach this discussion in a multidisciplinary, and I'm happy that the college selected speakers from various disciplines. Yesterday, I was asking Dr. Professor Ofori for yesterday's presentation. I saw RD by their names, and I was asking, but these are young people, why do we have RD? RD is retired, but later on I was told that they are registered dietitians. Maybe you have to change your RD so that the RD doesn't look like retired. So I saw MPH, PhD, RD. So I was asked, but what is it? So we completed retired. Then later on, I had registered dietitian. I'm very happy that the team came from various disciplines, Kolebu, and then main campus, and we've had this fruitful discussion. So colleagues, thank you very much for your time. The questions that you've asked, very, very relevant. The question about transplant, that is the best option, but still we have challenges with our law in terms of donation. So till that law comes, we are all going to operate the most expensive way, which is a dialysis. But for how long can we do this? For how long? I mean, I always tell everybody that in Ghana, we are all not paid well. And from the information coming, I don't think anybody in this room is prepared or can save towards such support if you have a relative. So please, let us take good care of ourselves and make sure that we avoid getting into the stage 5 of kidney. Once again, thank you very much, and we appreciate your questions and your inputs in the discussion. And a big clap for the 4 presenters.
Thank you, Prof. Santi. Thank you for spending 2 days with us. And we've taken up the challenge. So we look forward to seeing you at the dinner. And so, Committee Chair, I have accepted the challenge on your behalf. So we look forward to seeing you. May I kindly invite our Acting Registrar, Mr. Daniel Ameyal, to present the citations for us. Let us welcome him with a round of applause.
Thank you very much, Madam MC. Professor Chair, distinguished guests, we have 2 members of the Binary Scientific Conference and Public Lecture Planning Committee who have retired from the services of the university and would like to appreciate their efforts and honor them this evening. With profound respect, I invite Mr. Charles Stevens Ankama, or representative, to come up stage. University of Ghana College of Health Sciences. Citation in honor of Mr. Charles Ankama Stevens. Mr. Stevens, Charles Ankama, you served on both the College Binary Scientific Conference and Public Lecture Planning Committee and the College Newsletter in Focus Committee from August 2022 to July 2025 as a representative of the Medical Illustration Unit of the College of Health Sciences. As a medical artist, you were instrumental in producing relevant artworks and conference materials such as name tags, book of abstracts, certificates, posters, and calligraphic services, a job you undertook with all seriousness and dedication. You were respectful, friendly, and hardworking, and you accomplished assigned responsibilities with due diligence. We, the members of College Binary Scientific Conference and Public Lecture Planning Committee, as well as the College Newsletter Committee, appreciate your contributions towards the success and achievement of the 2 committees. In recognition and appreciation of your outstanding contributions, your selfless dedication to duty, and sterling performance, the College of Health Sciences is proud to honor you with this citation. We salute you for your efforts. I go. I now call on Mr. Frederick Kisei, our representative. citation in honor of Mr. Frederick Kisei. We extend our warmest congratulations to you, Mr. Frederick Kisei, on the occasion of your retirement. And we celebrate your outstanding 42 years of meritorious services to the College of Health Sciences and the university. Your leadership, guidance, and mentorship have touched countless lives. It was under your leadership that the Vice-Chancellor recognized the work of your subordinates, all thanks to your selfless dedication and great tutelage, which went unnoticed. Your communication skills and collaborative spirit shone brightly as you served on the CHS Advisory Board, Admissions Board, College Executive Committee, Board of Survey, Congratulations Committee, that's the Congregation Committee, and in spearheading CHS outreach programs and orientation activities. Your exemplary work, ethics, have earned you the admiration and respect of superiors, colleagues, and subordinates. Congratulations, Mr. Kisei, from the College of Health Sciences. Shall we continue to give a clap of hands for both Mr. Kisei and Mr. Stevens, Charles Ankama. Thank you very much.
Thank you, Mr. Mayor. We've come to the end of the program. May I kindly invite Mrs. Mavis Osafo Edu to give us the vote of thanks. While she comes upstage, vehicle number VD14621 is a Belta Toyota. Can you please attend to your vehicle? You've blocked someone. Thank you.
Thank you so much, Madam MC. A heartfelt vote of thanks. Good evening, distinguished guests, ladies and gentlemen. I deem it a great honor to be called upon to move the vote of thanks at the close of what has been a truly memorable and insightful event. We give God the glory for the opportunity to witness this day and for all the lessons we have learned. On behalf of the organizing committee, I would like to extend our deepest gratitude to our chairman, Professor Felix Ankuma Asante, Vice-Chancellor for Research, Innovation and Development, for graciously steering affairs over these past 2 days. Your leadership and insightful remarks were truly invaluable. Shall we please appreciate our chair? Thank you, Provost. To Professor Michael Ofori, Chairman of the College of Health Sciences 25th Anniversary Planning Committee, my chairman. Yes, please give it up to him before I continue. Who ably represented the Provost of the college this evening. Thank you for your warm and inspiring remarks. We are immensely grateful to our brilliant lecturers, Professor Vincent Boema and Dr. Jumwa Edu, for your thought-provoking presentations. Please. Thank you. Ladies and gentlemen, I believe you all agree with me that these past 2 days have been nothing but insightful, informative, and truly life-changing. Please help me once again appreciate all our 4 distinguished lecturers. We truly appreciate you. For some of us, it has been a life-changing experience, and we appreciate every single lesson we have learned. May these lectures inspire a national dialogue and policy framework for the prevention and management of chronic kidney diseases. A big thank you to our dynamic MC, Dr. Frederica Dedo-Party, for steering us so masterfully. Please, let's give it up to her through the evening, and to Professor John Ganley for facilitating such a lively and engaging question and answer session. Please, yes, I like applause. A special note of thanks to the chairman and members of the College of Health Sciences 25th Anniversary Planning Committee, the Biennial Scientific Conference Committee, and the Public Lecture Planning Committee for your hard work and dedication that has culminated in this eventful and memorable occasion. Finally, to all of you, our distinguished guests, both here and online, participants, faculty, staff, and students of the University of Ghana College of Health Sciences, the premier college of the premier University of Ghana. Please give it up to yourselves. Thank you so much for your presence and active participation. Your support and enthusiasm are what made this event so meaningful. To our alumni, sponsors, media partners, and every one of you who contributed in diverse ways to make this event a success, we say a big aigo to you. Thank you all once again for your patronage, and may God bless us all. Thank you.
Thank you, Mrs. Sedu. Before we began with God and we'll end with God, but a few announcements. When we close, we would take a group photo, so please be patient and we would stand on the podium and take a photo. Also, we do have refreshments when you come out of the hall to your left, so you can grab refreshments. I would also like to say a very special thank you to the committee. So there are 2 committees. We do have the 25th Anniversary Committee, which is chaired by Professor Furi, and then the committee that organized and planned the lectures. If there are any members, committee members here, can you please be upstanding so we can appreciate you? Thank you. You've done an amazing job. Thank you very much. And also, a very special thank you to our colleagues from the Sign Language Department, Dr. Sewa Mediam Pondusu, thank you very much, and Mr. Charles Mensah Ahinto for helping us out, so our colleagues can also follow us. At this moment, I would call on Reverend Dr. Alfred Dixon Dai Kosi to give us the closing prayer.
Thank you very much, MC. Please let's kindly rise so that we can pray. When Professor Boima was talking, he said, as they interacted with the policymakers, they said they have a threshold which they have to meet before they decide on taking a state of emergency declaration. You and I, we are in this state. The environment is being degraded. Our foods, our water bodies are being completely polluted. It takes only you and I to cry out to the Lord. We have to now cry out to the Lord so that the Lord, the God we serve, will intervene. Because in Proverbs 21 verse 1 says that the heart of the king is in the hands of the Lord. That heart flows like streams of water, and He can direct that heart in how He wants. I want us to rise up now and pray to the Lord to intervene on behalf of Ghana, so that the policymakers will be touched. So we'll go through a corporate prayer now and pray to God, our Lord, intervene, touch the hearts of our leaders, touch their hearts and turn them so that they will be favorably turned to look at this problem that we have. Let's rise up and let's pray now. Father, we thank you, we worship you, we give you all the glory, we exalt you, we magnify your name for your intervention, for your blessings upon the nation of Ghana. We pray that you continue to lead us, take charge over this country, all the challenges that we are facing. May you intervene, especially touch the hearts of our leaders, those in political positions, those in all forms of technocrat positions. You intervene and lead. We also have our policymakers, our academics who go to interact with these people. We are praying for special wisdom. We are praying for special wisdom. If Professor Boema goes to meet them and his team, we call upon God to give them that wisdom. In James 1:5, it says that if we seek wisdom, we should call upon Him. We are calling upon you now, Lord, to grant them the wisdom, how to convince them to take the right decision, so that we all will be saved from this calamity that is looming over the country Ghana. Continue to pray that, Lord, your Holy Spirit, you touch the hearts of these people, provide that wisdom to our leaders as they go to interact with the policymakers, so that the right decisions will be taken to save this country. We thank you, Father, we worship you, Lord. When all thy church triumphant, we joyfully adore you, till thy Appiah, thy members here shall sing like those in glory. We lift our hearts and voices with blessed anticipation, and cry aloud and
give you all the praise. Continuous mercy upon you. We pray that your Holy Spirit will continue to go with you. We continue that your grace will abound for the nation. Touch the heart of our leaders. Touch the heart of our leaders. God, they will know that with the Lord, thank you so much for the situation of the college and the science. All the leaders, all the presenters, with the Lord, go home. We have these blessings that have been given unto us. Blessings that from here. Holy Spirit, go with them. When it's against the violence of the enemy, that is the mercy. Now, thank you, Lord.
Thank you all for coming. Thank you all for coming, and we look forward to seeing you at our next event to mark our anniversary. Safe travels back home, And may the spirit of collaboration continue to inspire us all. Can we please come forward to take the photo?
Some of us should come down. Prof, you have to be in that seat. And you have to come bad way, bad way. Are you sure you'll be seen?
Online.